Hello, this is Amjad El-Mendilawi from Baghdad, Iraq. Today we are going to present a case of left mainstem that is heavily calcified, also calcification involving the LID. First of all, we are going to present the case, and the case is going to be presented by Dr. Abdul Karim, who is a final year of cardiology board.
Okay, thank you, sir. Our case is 74 years old male. He is hypertensive, non-diabetic, lifelong non-smoker. His presentation is chest pain on exertion lasting for 3 months, and the pain was relieved by rest and sublingual nitrates. And so he was referred to our hospital for coronary angiography and possible PCI.
Okay, angiography was done for the case and showed left mainstem with LID and possible intermediate lesion in the circ. We will show the angiography now. The patient was referred for coverage. He is a clear-cut case for surgery, and he was seen by the surgeon, but totally refused surgery, and he asked for our help. So let's review the angiography. So this is the angiography done 1 month ago. Shows a near normal right coronary artery. And this is the left system. It's clear the left main distal critical lesion with the proximal LID and mid LID critical lesion. Let's see other reviews. Actually, the case is a trifurcate left mainstem. And you can see that the proximal LID is nearly subtotally occluded, and there is a ramus branch and the circ branch that looks, there is a plaque, but rather non-critical. If we review the left main from the cranial view, we can see the heavy calcification. It looks like a rock at the distal part of the left mainstem. So, Dr. Abdul Karim, what do you think? What are we going to do? What do we need for such case with heavy calcification of left main and the LID?
Okay, sir. Based on we have heavily calcification in the left mainstem and proximal LID, we have to prepare our case and prepare our instruments. Our instruments, we should use a catheter with good support, like XP catheter. And we also use balloons, cutting balloons and IVL, Shockwave balloons. We need also under guidance of IVUS study to ensure that the left mainstem, sizing of the left mainstem, and to localize and the calcification of the LID and left mainstem. Yes.
So, so the principle in this case is that we need some imaging to identify the type of the calcification. We have calcification, we have extensive calcification, but we have to identify the type, whether it is circular and the length of the calcification, and whether it is nodular. Because the left mainstem, it looks to be like a distal left mainstem nodule. And we need some debulking devices. To me, I think we cannot pass anything in this proximal LID. So I think rotational atherectomy is going to be the first thing that we are going to use. And after that, we are going to image the coronaries, and probably we'll use some specialty balloon, starting with the NC and higher pressure balloon, and maybe we need some cutting balloon at the distal left mainstem. So the principle is good preparation of the lesion and then stenting. Okay, shall we start the case?
Yes.
So we started right away with the rotational atherectomy, and to do that, we cross the lesion by a workhorse wire, and then we have to change by a rota wire through a microcatheter. Here we are passing our rota wire through the microcatheter, and now we are pulling back our microcatheter so that we can use the burr over the rota wire. Now we are using a 1.5 burr over a floppy rotawire, and this is the first run going through the left main stem. You have to give some rest and go again. It's a hard distal left main stem. Now we cross the distal left main stem. We have to cross the subtotal part at the proximal LID. And now going another run, trying to reach the bifurcation. It's not easy at this part. Sometimes when it's not easy to cross this part, a distal lesion that is heavily calcified and imposes resistance to the burr, it might be better to advance through the sheath and the burr, advance it through the dynaglide, that is a low rotational speed, so that you become closer to the lesion and then you advance it. Let's try again. You see we are stopping short of the distal lesion near the bifurcation of the LID. And this is the third run. Let's see where we are in the apicodal view. Yeah, the proximal part is opened and there is some significant spasm in the LID. And we try another run here. Again, it stops near the bifurcation. Let's give it some rest, and then we advance the sheath closer to the bifurcation. Go epicranial. Now we move the sheath closer to the bifurcation, and now we are starting another run of rotational atherectomy. It's going a little farther. Yes, this is a little bit better, but it's not advancing beyond the bifurcation. So let's try again. Yeah, the sheath is the burr is going up to the bifurcation only. It's advancing a little bit more, yes. But the patient is having chest pain, and we can see ST elevation on the ECG. The pressure is okay. So maybe now it's better to pull back the burr and the sheath. Yes. Let's do angiography. And yes, you see there is some spasm. Still there is some chest pain with the ST elevation. We have to do some pre-dilatation and give some nitroglycerin. Okay. Now let's pass a workhorse wire into the LID. It's easier to deal with than with the rotawire. Then passing a balloon 2.5 NC balloon 2.5 by 20. Inflation starting distally at the bifurcation. Going first to nominal, there is some waste. You have to pull back a little the balloon and then go to 20 atmosphere. The inflation is a little bit better. Off. And now inflating the left main stem after giving some rest to the LID. So after pre-dilatation and nitroglycerin, we are doing angiography, and this is how the LID looks. It's very much better. The ST elevation returned to back. The patient is now free of chest pain. But as you can see and notice, we can see a distal lesion with myocardial bridge. It is more apparent now, but I think we are not going to deal with that. Now we are going to take out the rota wire and work with only the workhorse wire. And now it's time for IVUS after passing a wire into the diagonal. This is the IVUS catheter. It's not easy to pass across the bifurcation. Okay, now we are passing, and we'll start imaging from the distal part of the LID. So let's review the IVUS imaging. So let's review the IVUS, and this is the pullback from the LID. This is, you see, is the distal LID where there was a lesion and probably a myocardial bridge. And if we come more proximal, we can reach into this. This could be a good landing zone. Let's measure this part. Yeah, it's around 3.6, so at 3.5 millimeter stent would be okay at this part. And with further pullback, there is some softer plaque, and this is, here we come to the bifurcation with the diagonal. And here we see an arc of calcification. You can see around 180 degree, and this is the wire coming out from the diagonal. And here even more than 180 degree calcification, and this is the septal branch. So we may regret that we didn't did the rotational atherectomy at this part. And with further pullback into the proximal LID, we can see the extensive calcification around 180 degree, and actually is protruding into the lumen. But after this dilatation, the lumen is widely patent now, so we can pass our equipment. And with further pullback here, this plaque is more fibrotic, and the proximal LID is again calcified up to the main stem. And now we have artifact, so we have to repeat this part, and let's see. This pullback is from the bifurcation. Here we can see the carina of the left main stem with a branch which is probably the ramus, and we can see the calcification is on the opposite side of the carina. With further pullback, and this is probably the left circumflex, and this is the arc of the calcification protruding into the lumen. So this is the part that is heavily calcified, distal left main stem, and around 270 degree of calcification. And what prevented more calcification, I think, is the branch. And with further pullback into the left main stem, there is still some calcification, and here we can see the septal, or a branch from the left main stem, which is unusual, but it can happen. So let's measure the left main stem, and if we measure from here to here, it's around 4.5, probably a little bit more than 4, 5.4 and 5.6, so a balloon post dilatation of 5 would be enough. And now further dilatation is done by NC balloon 3 mm, 320, going first to 12, and then to be followed by the burst pressure. It seems to be fairly well dilated at the bifurcation. The balloon expansion seems to be okay, although it's better to assess in an orthogonal view. And now we have to dilate all even the proximal LID by this balloon. And we are going also to dilate the left menistem. Yeah, and a 3 mm balloon, of course, is not enough for the left menistem LID, proximal LID, the LID being 4 and the left menistem 5. So we need further preparation, but let's inflate first by this 3 mm balloon. And I think we need to take a cutting balloon for the distal left menistem. You see the calcification is pushing the balloon, and there is some waste on this NC balloon. And now we are using a Wolverine cutting balloon 3.5 by 12. At the distal left menistem and proximal LID. Let's see. Yes, it's a good position. And inflation up to 6 atmosphere. The deflation should be slow as recommended by the manufacturer, so that the blade would go into the infolding of the balloon, and when you pull it back it would not injure the vessel. But actually in practice we forget that, and the operator and assistant deflate rapidly. Although here we have the left menistem and probably we need some rapid deflation. Now the deflation was slow, it's okay, and maybe we need to go a little bit higher pressure. So let's go again. And now we are going to go 12 atmosphere. Yes, and there still seems to be some waste there. Yes. Deflate. Okay. And now let's repeat the IVUS after the cutting balloon. You see it's not easy to pass it because the calcium is protruding into the lumen. Now we can pass, okay. And let's review the IVUS. Now we have the pullback after cutting balloon. This is the LID. This is the bifurcation with the diagonal. We often find that after dilatation of the vessel, the IVUS pictures become better because when it is tight, I think there is some pressure on the rota drive, on the drive shaft, that will make the picture less clear. And here we can make better measurements. So let's see, this is the bifurcation, a little better with the diagonal, I mean, a little better, not very much. And this is the proximal LID, the same calcification. And if we go back up to the ostium of the LID, here we can see dissection and hematoma at the ostium. This is the LID, this is the ostium of the LID, and this is the dissection at the LID ostium, pulling back up to the left main stem. The lumen a little bit better, but I think more need to be done to this arc of calcification. It will not open. And here the left main stem. Okay. So what more can be done? We have used rotational atherectomy followed by high pressure balloon 2.5, then 3, and then we used cutting balloon, which was 3.5. One may take a larger balloon for NC, or one may argue that we could have taken a larger burr, that is 1.75 or even 2. Okay, that can be done. But I think for the left main stem we need to take an IVL, a shockwave balloon. And so we have taken a shockwave balloon 12 millimeter. The important thing about shockwave balloon is the sizing. And depending on the IVUS, the LID proximal part is 4 millimeter and the left main stem is 5 millimeter. The important thing about sizing is that the wall of the balloon should impinge on the wall of the artery, otherwise the imaging, the shock and the energy will dissipate into the blood. So a 4 millimeter balloon, this is the largest one is available, C2 plus, that has 120 runs. So we use this balloon for the distal left main stem proximal LID. And as you see, we inflate to 4 millimeter low pressure and then to 6 millimeter, and we have given a lot of pulses, and still there is a waste. So we used around 90 runs for this 4 millimeter by 12 IVL balloon. And we can show the waste using Stent boost. This is the Stent boost. We are using it for the balloon, and clearly you can see the waste on the IVL balloon, and look at the chunk of the calcification, how it's pushing the balloon, the waste of the balloon. So we are using around 9 runs, that is 90 pulses for this shockwave balloon. Now we have the IVUS run after the IVL balloon. Here we can see this is the ramus, then the circ. The lumen looks a little bit larger, although not discernible fractures that can be seen in this view. But it is larger. The IVL you may not see fractures by IVUS, but at least it increases the compliance of the calcium. And we can also observe that the hematoma is extending into the distal left main stem. Now all the preparations that have been done, now we have to go for stenting, and we decided to take a 3.5 millimeter stent for the LID and a 4 millimeter stent for the proximal LID to the left main stem. And since we don't have all the lengths of this stent, we used a balloon 20 millimeter for sizing, so probably a 3.5 millimeter 24 for the distal LID, and a 4 millimeter 24 again with an overlap, it's important that the overlap should not be done at any bifurcation, neither at the left menistem nor at the bifurcation with the diagonal. And here we are passing a 3.5 millimeter by 24 stent into the LAD, trying to get at the distal to the bifurcation, but it's not easy. Probably the wire of the diagonal is impeding the passage of the stent. Let's see with better support, pushing the guide. I think we pulled out the diagonal wire, and it was even again difficult to pass. Maybe we need a body wire to pass to the distal LAD. Here we are using the diagonal wire as a body wire, and let's see if the stent will pass over the wire using a body wire. With a little bit of a push, I'm pushing the guiding, and the stent passes. It's okay. Now we have to pull back the body wire. Now our stent in position. It's a good position. Inflating 10 atmosphere. Needs further dilatation at the waist, so we deflate and pull back the balloon a little, and then go to a higher pressure. Seems to be okay, the inflation of the balloon of the stent. We can also use this balloon for sizing for the proximal left main to LAD. Further inflation. Now we are passing a stent 4.0 by 24 after protection of the ramus and the circ by wires. And here we check for the overlap and for the left menistem. We are not very much concerned about accurate positioning at the ostium of the left menistem. We don't have to cover it all, but this position seems to be okay. And here we are inflating it. The inflation looks okay, not bad, but of course we need further dilatation by high pressure balloon. And now we have to go for pot, but let's further inflate it further to get its proper size. Let's do some angiography before further dilatation. Let's look. It looks okay. Distally no dissection. The diagonal good. Optimic flow 3. Now we have to do pot for the left menistem. Here we are using for pot for the left menistem a 5.0 millimeter in diameter balloon with an 8 millimeter length. The position is okay, is just before the carina, and we are going to inflate. (10 atmosphere). We need to pull back the balloon a little and go more. Up to 14 atmosphere. Again 14 atmosphere. Now we need to post dilate the LID stent by 4O NC balloon up to 16 atmosphere. We'll pull it back and post dilate up to 20 atmosphere. And let's go to the bifurcation for the left main stem, again 20 atmosphere. And this is the angiography after post dilatation. The stent seems to be okay, but we need recrossing for the circ and ramus and dilatation of their ostia. Let's take another view, spider view maybe. Yeah, it's okay, but we need to recross and do kissing inflation. We pulled back the ramus wire, increase its angle, and it's important not to go retro-stent. That's why a properly sized pot balloon for the left main stem is needed. And the other way is, as we did, you go in a J shape into the main vessel and then pull back the wire and go through the strut up to the circumflex. Now we have to take out the circ wire and go into the ramus. Our aim was to do a trizic balloon inflation where 3 balloons are inflated at the same time in the circ, ramus, and LID. So we parked two O balloon in both the circ and the ramus, but we couldn't pass a third balloon 4O in diameter with this guiding catheter. So we have to make some modification for this technique and some modified kissing inflation or modified side pot. And here both 2O balloon are in the circ and the ramus, and we inflated each for 20 atmosphere. atmosphere. And then doing kissing inflation between both the ramus and the circ. This is considered like the side branch inflation. After that, our aim would be to inflate or do kissing inflation with the LAD and the ramus. And here we have a 4O balloon in the LAD left main stem and the 2O in the ramus, and we are doing the kissing inflation through the LAD and the ramus. Now we need to do report by a 5O balloon, but before that let's make IVUS. Let's do some IVUS and see the state of the stent. And this is the IVUS pullback from the left main after stenting and the kissing inflation. You can see the distal part it's on a plaque but well dilated and circular. And coming up to the bifurcation with the diagonal, it's okay. There is some impingement, but the lumen is widely patent. And then comes the proximal LAD. Again, it is well opened after inflation by a 4mm balloon. And then we come to the ostial LAD, and here comes the bifurcation, distal left main stem. It's not regular, but it's a good luminal opening. Let's see the area. If we can measure here, it's not circular because the impingement of the calcium is around 12mm, which is very good. And then the left main stem itself widely patent, and this is the proximal left main stem. The ostium is not covered, so actually it is good. We need to do the final pot after kissing inflation. And here is the final pot using a 5O balloon for the left main stem and inflation up to 16 atmosphere. And this is the angiography after final pot. The result seems to be satisfactory. The circostium is okay, the ramus is good, and left main stem LAD are both in this view are okay. You see the tortuosity in the proximal and mid part of the LAD. So let's go for the cranial view and see the distal part and the distal left main stem. And before that, let's see the spider view. Yeah, it's okay. Both the ramus and the circ are patent. We do not need to go and complicate things further. It's already complicated by the high calcification burden. You see even by fluoroscopy the chunk of the calcium outside the stent. And this is the result. There is some impingement, but widely patent distal left main stem, the LAD, the diagonal, and we can see that branch coming out of the left main stem, which is probably a septal branch, is also patent. And by this we finish the case. To wrap up the case, it was a left main stem trifurcation, an LAD bifurcation with heavy calcification. And we needed to use all the equipment for calcification available at our cath lab, including rotational atherectomy, NC balloon, cutting balloon, and even the Shockwave IVL balloon. And by that, I would like to thank the group that worked with me, Dr. Abdelkarim Al-Ghazi, a final year cardiologist who assisted me with the case, Surah Malham and Dulfiqar, both are technician, Ali Farouk, the nurse, and Ismail, the radiographer. And thank you.